Yeah. Good morning, everybody. Thank you for invitation. We come now to our patients with severe COPD. I'm a pulmonologist, and work on the intensive care unit in Cologne now. And we have a lot of patients with severe COPD in Cologne. Nearly everyone is smoking there in the city. So we have, in the beginning, some main problems in mechanical ventilation we see every day. We have in severe COPD exacerbation, it leads to an overload of the respiratory muscles, you know it, and it results initially in a respiratory pump failure. And the main pathophysiological mechanism are the severe airflow obstruction and the dynamic hyperinflation. And especially the hyperinflation is very difficult in ventilation, I guess. And due to this expiratory flow limitation, low breathing frequencies, especially if you go to invasive ventilation and in a controlled mode, with a sufficient alveolar ventilation are highly important, that you do not increase the frequency too high. NIV is in a way the standard of care or state of the art for patients in acute exacerbation, in avoiding intubation and improving outcome, but all the studies that were made were with selected patients, I will come back to this later, which were presented with acute hypercapnic respiratory failure and had a pH value between 7.2 and 7.35. Assisted mechanical ventilation, I guess, is in severe COPD more difficult even than in ARDS, I guess, because of this high dead space ventilation and the low flow variations we have at the tube. So this is what we see every day, the severe hyperinflation. If the patient is not on ventilation, we also use other ventilators than the servo I. So if you see here, what you can see every day, that you have at the end of the expiration, there's still flow left and there's still pressure left in the lung, although you have an IE ratio of 1 to 2. So first, NIV. We know that NIV is superior to invasive ventilation, I would say, if the pH value is between 7.2 and 7.35. And that's very important. The number needed to treat to prevent one intubation with NIV is very low. So we need only 5 patients to prevent one intubation, and we need only 8 patients to reduce significantly the mortality. I guess that's very clear, and that's changed very much the treatment of the patients during the last years. We have a part of the patients, although they had success in the beginning. That's one of this landmark studies we had around about 10 years ago from Stefano Nava's group. And you see that even if we succeed in the beginning within the first 24 hours, we have a part of the patients who fail after 24 hours. This is what we also see every day. And the one question is it due to the trigger? And this is, I guess, one of the rationales for NAVA in COPD, because NAVA, as you all know, is completely independent of the pneumatic trigger, and I guess, therefore, it's the ideal trigger for our hyperinflated patients with COPD. Second, with NAVA, the patients get more independent of types of masks. That's also, as we heard it yesterday with the helmets, because they are completely independent of it. And second, independent of the trigger, with NAVA, the patient's respiratory center has a choice and should aim on the homeostasis of the pH value. I'll come back to this later in the next talk with the ECMO, because it was a nice study we did, and we could prove this hypothesis. So some screenshots from patients with severe COPD. This is what you see every day, that you have the Druckunterstützung is the German word for PSV in this mode, and this is what we see every day. Even without NAVA, you would see that there are ineffective triggering for these patients if you have a look at the diaphragm activity. The second patient is typical, we saw it yesterday. This is the underlying breathing frequency in the patients with COPD. And the flow trigger, we usually use a flow trigger, not a pressure trigger. The flow trigger is as sensitive as you can in these patients. Have a look here. That's, we observe sometimes very high EAD levels, up to 100. I have no idea why, but sometimes in some patients we have it. The PEEP is a little bit too low. If you would increase it, it's easier for the patient to trigger the machine. But this is what we observe every day. I call it, like in this case, I call it a respiratory block. second degree. Yeah, you see it. Every second breath only counts. It's what we observed several times in patients with COPD, that only every second breath counts. I have no idea why. So if you go back to this example in this patient, this is the breathing frequency the patient gets if he is in the PSV mode, and this is what the diaphragm wants, or what the patient's respiratory center wants. And now if we go to NAVA, we have a perfect synchrony, and this is what we observed in nearly all of our patients. And everything he wants is translated into pressure and therefore into flow. So the rationale is, or what we observed is, NAVA is superior to PSV in these patients, in invasive and in the non-invasive modes in terms of synchrony. It's highly comparable to all the other diseases that were reported during the days here. It's also like in children, like in meds. And our observations, we did not publish the data yet, but the synchrony is more than 95%. But my main question is, does this synchrony really lead to a better outcome in the patient? That's very important. And there is, I guess, one uncertainty factor, I would say, in these patients. And this is the breathing frequency. If you look here, if you go to NAVA, in this patient, he has suddenly a breathing frequency of 40. And that might be dangerous in patients with COPD. Because this is, as I told you before, if you have no airflow obstruction, that's no problem. But if you have a high breathing frequency in COPD, it leads to more and more trapped air. So this is a dangerous part in ventilating these patients with COPD, because the expiratory time might be too short in this high breathing frequencies. And what we have to keep in mind, patients with COPD have the highest neurorespiratory drive. This is one of the study by Jolly, and if you see around about 10% of the maximum of the EMG we have in a healthy volunteers, and this is what we also observed with NAVA. You can also look very nice, it's around about 25%. So COPD patients do not have a low respiratory drive, they have the highest respiratory drive we can imagine in all the patients. So the treatment aims, if a patient comes to us for NAVA, especially in the NIV mode in severe exacerbation, is a short-term aim we have, and that is a decrease of the real breathing frequency towards a physiological frequency, and I guess this is below 25 or below 25 to 30, and this is what we saw in all our patients. I never observed a patient who had more severe hyperinflation on NAVA, but we will see within the next months if we have one of these patients. And then the first treatment aim is to stabilize or increase the pH value within the first 30 minutes to 120, I would say, and then effectively unload the diaphragm. And then second, we have the long-term aim would be avoid this late alert, avoid this late NIV failure, and then only slowly decrease the CO2 towards normal levels. And now the question is, how could we prove that NAVA is superior to conventional NIV or to in the invasive or non-invasive mode? And this is what we would like to propose. So I guess we would like to go further to a multi-center trial. And I discussed it with my boss, Wolfram Windisch, several times, which would be the best setting for such a trial. Do we go in the beginning, if they are in acute exacerbation? Do we go to invasive ventilation? Do we go to weaning? And we end it every time at the same point. Because of NIV is, or I would say, NIV synchrony in severe COPD is even more difficult than in the invasive mode. So we will see the highest difference in the NIV mode. And I guess that we would like to design a study where we go to the acute exacerbation with a pre-randomization for each center. And then if the patients present with an acute exacerbation, we would accept pH values from 7.15. We can discuss it up to 7.35. And then the patients have to be randomized to PSV. We need a PEEP level, I guess, around about 5 to 8, and a driving pressure which is high enough that we have enough alveolar ventilation. And then in the second arm, we would do it with a non-invasive load, with a high unload in the beginning. I guess that's very important. And then we increase the load of the diaphragm within time. So we would propose an international study group. We could coordinate it from Cologne. But we need several centers. And I guess it's very important that we have 2 preconditions for each center. And I hope here are some who would like to participate in this study. And these are two facts. You have to be familiar with the treatment of severe COPD exacerbation. That's very important with NIV. And the second, which is very important, that you have to be familiar with NIV-NAVA. And then we guess we need 1 principal investigator, 1 sub-investigator from each center. And of course, we need the input from the opinion leaders in these fields. And we need a sponsor for the study. Marquet would be perfect. I received some very nice signs from Marquet. But I guess we should have a look on science and not too much on company. The inclusion criteria, in contrast to all the other studies that were made with NIV in acute exacerbation for COPD, we would say, but we can discuss that in an open-minded fashion, that comorbidities are possible because we want more to go to the real-life setting if a patient presents in our department. The respiratory acidosis, we can discuss 7.15 or 7.2. The age, I guess, should not be too old, and these are the typical exclusion criteria for non-invasive ventilation. And the primary endpoint for this study would be the intubation rate, because it's already proven that NIV is better than invasive ventilation, that we need a very low number needed to treat to save 1 life. So for this study, I would say we need, as a primary endpoint, the intubation. And mortality and synchrony are only secondary endpoints. For me, what's very important is a follow-up in the patients with a severe COPD exacerbation, although it will take a long time for the study. But follow-up in severe exacerbation is so important because we have a patient group which has only 1 or 2 exacerbations per year, and we have others with 5 or 10. So the follow-up during the first year is highly important. So in conclusion, I guess NAVA is superior to PSV because of its independency of the pneumatic trigger and excellent synchrony. The high respiratory drive is an uncertainty factor, but usually patients decrease breathing frequency, especially with NIV-NAVA. And we guess that we need an international multicentre trial to show an advantage for it compared, and therefore we suggest such an international study group, and we would like to coordinate it from Cologne. And if you want to participate or discuss it with me, this is my email. Thank you very much.